now I would like to invite the moderator and the speakers of the last session, a very interesting debate on laparoscopic rectopexy, resection versus no resection. So the chairperson of this particular debate is Dr. Vandana Soni. And as we all know, she is the director of laparoscopic minimal access metabolic and bariatric surgery at Max Super Speciality Hospital at Saket in Gurgaon, in Delhi. And we have the two speakers, Dr. Suviraj and Dr. Lakshmi. So Dr. Suviraj John is a consultant laparoscopic and robotic surgeon empaneled at the Sir Gangaram Hospital. And Dr. Lakshmi Kona Kumari is a senior consultant in surgical gastroenterology, minimal access GI surgery and bariatric surgery at Gleneagles Hospital, Hyderabad. Both are very well known, and actually all three of them are, we look forward to a great session on laparoscopic rectopexy. Over to you, Dr. Vandana. Are you there? Dr. Vandana?
Yes, thank you, Dr. Meenakshi. Thank you. Yes, I'm very much there. And I think this is the last session before the plenary sessions begin. And without much ado, I think I don't want to take too much of the speaker's time. This session is going to be a debate on laparoscopic rectopexy, resection versus no resection. Now, as mentioned in the program, there's been a switch of topic between the speakers mutually. So we are first going to have Dr. Suviraj John speaking to us about laparoscopic rectopexy without resection. So do we have Dr. Suviraj online?
Yes, I'm here. I hope you can hear me.
Yes, Dr. Suviraj. So Dr. Suviraj, as Dr. Meenakshi mentioned, is a senior consultant and at IMAS at Sir Gangaram Hospital. Extensive experience he has in minimal access and coloproctology. And looking forward to your debate, your session. Dr. Suviraj, you have 10 minutes to present your points in your favor, and then we'll move over to Dr. Lakshmi before we have the departure.
Just a small update. We have some more time because the plenary session has been postponed by around 10 to 15 minutes. So we can have 5 minutes each more from each speaker.
So I think that depends upon, that is, of course, added advantage.
I'll try to keep the time and then we can use it for discussion maybe.
Yes, we can have a slightly longer time for discussion.
Yeah. May I start?
Yes, please.
Thank you very much, Dr. Vandana and Dr. Meenakshi, for a very kind introduction. It's a wonderful experience to be back, although in a virtual sense. My duty this evening is to defend my position of a laparoscopic rectopexy without resection for rectal prolapse. By saying rectal prolapse, I mean in the adult, full thickness rectal prolapse. And let me start by saying that this is actually a therapy which is continuously still evolving. And that too against the background clinically, which is highly heterogeneous and pleomorphic. So one needs to be very careful before we actually make broad sweeping statements. A little context, pelvic floor disorders amongst which rectal prolapse comes, although is a minority in terms of our total coloproctology work, but it is still a significant, part of our surgical work. I hope I'm audible now. I've taken off my mask. And although in comparison to rectal cancer, our laparoscopic practice as an institution has been lagging behind, there are still a number of surgeons who actually perform perineal procedure for old people for rectal prolapse. This is a comparative statistic with rectal cancer. You can see there's a far greater uptake. The central question here we have today is, should we excise or resect the redundant sigmoid? And can we tolerate the issue of anastomotic breakdown? It is my position that laparoscopic rectopexy without a resection is a solid, rugged procedure with good long-term outcomes, and that we really can't accept the morbidity and sometimes the rare mortality associated with a resection and associated anastomotically. A quick snapshot. Overall, resective procedures as you can see, whether it's open or laparoscopic, have a better or a more successful outcomes in terms of recurrence, lower recurrence, but they have a significant, although the recent, but still not negligible morbidity, and yes, even in certain cases, mortality. This needs to be taken into context as we step into the minimal access arena. Laparoscopic and robotic surgery gives us many benefits of minimal access surgery. You can see a list of them here, and this has been a game changer apart from the minimal access advantage for rectal cancer, for rectal prolapse. How so? It has now made it far more possible and safer for us to bring the elderly category of patients into a transabdominal procedure for laparoscopic or robotic access. Now, when we come into objective, hard-nosed comparison between resective and non-resective procedures, we must accept the limitations that we don't have a lot of publications with head-to-head comparisons. There is a selection bias. If a surgeon likes a procedure, he does it predominantly. And there's a huge variation in technique. There's almost more than 100 types of approaches and procedures for rectal prolapse literature. But over the last few years, if not decades, there's been a focus not just on restoring the anatomy, there's also focus on restoring physiological function and preserving it. Thus, the NDT approach is valid today, and we start to look at this through very hard-nosed clinical outcome measures. I'm going to quote a few simple studies to highlight my position. In 2015, we had a Cochrane group analysis. It looked at primary outcomes and secondary outcomes in a head-to-head comparison. They only found 3 studies which fit their criteria for a comparison between resection and non-resection rectopexy. Primary outcomes mainly relating to success in relation to recurrence, as well as incontinence and constipation. Secondary outcomes relating to quality of life and physiological indices. What they found was for recurrence as well as fecal incontinence, there was really no difference between the 2 categories. But in terms of constipation, there was significantly less constipation with the resection group. This might sound like a support for resection, which seems to be supported by other evidence. But when you come down to the quality of life indices, there's greater compliance when you look at non-resective procedures. And gut transit time, which is a function of constipation, was supported in this. Central to the issue of the debate, maybe we can come into the Q&A session for this whenever we have a discussion, is the issue of whether we dissect or transect the lateral ligaments or vis-a-vis a resection. The central issue is constipation. Constipation de novo occurs after rectopexy, which is non-resective. The reasons for this are many, some related to mesh placement, some related to the excision of the lateral ligament, which actually transect the parasympathetic supply to the rectum. This has been shown to cause constipation, and avoiding transection has been shown to prevent this. However, the evidence for this is early, and now we are actually having people who do partial transection or even nerve-preserving rectopexy. And I come to a little bit more detail from the American Society of Colorectal Surgeons. Their position statements published in 2017. They largely support the transabdominal rectopexy with essentially rectal fixation as a central theme. They believe there's insufficient evidence to choose, resection rectopexy over something like the anterior ventral or the ventral rectopexy. A quick note. We believe in our institution to do a laparoscopic rectopexy as the method of choice after counseling the patient, and thus we mitigate. We don't transect the lateral stalk, thus we preserve the parasympathetic supply, and we now actually move to a ventral rectopexy, and we've abandoned the posterior mesh rectopexy because that involved more of a circumferential dissection of the rectum. Now we see in suture rectopexy we have excellent outcomes in terms of recurrence and morbidity and mortality. This, when you compare with a resection rectopexy, there is a non-negligible mortality rate, although the recurrence rate is comparable. Just a note about posterior mesh rectopexy, although done in the past, we've abandoned it in relation to the dissection of the lateral ligament. And we now have actually moved on to ventral mesh rectopexy briefly, using non-absorbable mesh. And now actually they're counseling patients to use absorbable meshes as opposed to reduce the risk of mesh-related complications. And here we actually achieve a double kill. not only do we bring up the rectum and fix it, we also suspend the pelvic floor, which may descend at straining. A quick note about to highlight the laparoscopic ventral rectopexy. I've chosen one study from the recent past in 2017, where they actually performed the ventral rectopexy, a laparoscopic robotic or an open one, to even treat recurrent rectal prolapse. And what they found was good outcomes for both primary and secondary rectopexy. And yes, the people who had a primary repair went a day earlier to the recurrent prolapse patients. However, the overall complication rate is comparable between the two. And this I must highlight is because we don't mobilize the rectum. We only mobilize anteriorly. The non-resection fascia go into the rectovaginal septum all the way down to the perineal body, and then we place a mesh and fix it in a mildly loose fashion to take a promontory. And that's the operation. You don't transect circumferentially, you don't transect the lateral stalk. And we also found in this study that the recurrences, if they occurred, were largely in the recurrent group, and these usually occurred much early in this group compared to 30 months in the primary group. Overall, whether it was a primary or a secondary repair, the quality of life was much, much better. As you can see through all these different tools, from the Cleveland Clinic Global Quality of Life Index to the other quality of life indices here mentioned. So the take-home message with a laparoscopic ventral rectopexy, which is essentially a nerve-preserving mesh rectopexy, is an excellent modality for primary and secondary rectal prolapse. Note that in the case of the primary procedure being a Delorme or a perineal rectopexy, there is a slightly higher chance of recurrence. Coming back to the focus, which I believe is going to be part of the debate, is the issue of constipation, which may arise de novo if you transect the ligaments, and it can be mitigated in some cases by doing a resection. We believe that now with a nerve sparing and a lateral ligament sparing surgery, we have mitigated this, and we can, many people avoid constipation by lifestyle change and by dietary supplements. And we believe that a head-to-head comparison in the future may be delineated better by these upcoming trials in Germany, Denmark, and the UK. So evidence is evolving, but for the larger surgical population and professional community, we believe in experienced hands and also in surgeons who are learning that you can provide good long-term results with a laparoscopic resection. You can optimize your results by employing a multidisciplinary approach, excellent clinical evaluation and lab evaluation, especially a dynamic MRI, as well as good patient selection, do your technique well, and avoid constipation by preserving the lateral ligament. You do that by anterior rectopexy and also with medical management. Please reserve a sigmoid resection only for those with intractable constipation with a very redundant sigmoid colon, and especially a note about complications for a purely benign elective procedure. It's very hard for a surgeon to explain a life-threatening or a major surgical complication relating to anastomosis, especially in the elderly. So I believe in our context, in our native setting, laparoscopic non-resective rectopexy is the best option for most people. Thank you very much. I hope that is audible.
Yes, thank you, Dr. Suviraj. So I think that was a fairly good front or step forward towards defending your topic on laparoscopic rectopexy. Let's hear what Dr. Lakshmi has to say. Dr. Lakshmi, she is currently the head of department of at Gleneagles in minimal access and GI surgery department. Over to Dr. Lakshmi, very dear friend and an excellent presenter. So looking forward to hearing what you have to say, Lakshmi, before we come back to Dr. Suviraj.
I would thank.
I think Dr. Suviraj, you will have to stop sharing your screen so that we can.
I've already done that.
Okay, all right.
Okay, so Vandana, thank you for the introduction, and hi Suviraj. Meenakshi, and I will define my position on resection rectopexy. Surya gave an excellent description of the procedure. Actually, it is individualistic based. It depends upon the person. Why this is not moving? Who is going to get the procedure? We cannot just give a uniform procedure to everyone. So coming to what is resection rectopexy is when we remove a part of the sigmoid colon and restore the continuity, and then we also add the rectopexy to it. It's only just not the resection, so it's resection plus a rectopexy. And specifically it is used for patients who have constipation as a main complaint. So there are patients who will have normal bowel movements with the prolapse, and they'll be having constipation with prolapse. So if you are doing only a rectopexy, it could be a anterior or a posterior rectopexy, the constipation never improves. And most of these patients are over time got fixed to that bowel movement, because most of them would have ended with this prolapse because they have been constantly straining to pass the stool. So if we are not able to correct the constipation part, in whom constipation is a significant complaint, then they will be never happy even if their rectum is not prolapsing out, but still they'll be never happy because they are so bothered about the constipation, and they'll continue to strain, which is a very negative predictor when we're doing a rectopexy. So if we are able, and it has been shown that resection rectopexy gives a significant improvement in the constipation and also improves in the functional status, with only decreasing the recurrence rate significantly. So this so you have to get the patient through a whole lot of investigations, mainly because here you are going to resect the bowel. So apart from the manometry and all, you should do at least a sigmoidoscopy to make sure there is nothing within the sigmoid colon, not some obstructing growth or not some obstructing polyp. And difficogram is a must to see the degree of prolapse, and the fecal incontinence score severity should be assessed, and the patient should be mechanically prepared. I will just show you a short video. So because to understand what the procedure entails, so that's the port placement. The patient is in lithotomy, and then the ports are placed so that we have adequate triangulation. So why I wanted to show the video is to see that when they have a large, you can see that's the large redundant sigmoid. So when they have a large redundant sigmoid, and we just mobilizing the rectum and then fixing it is not going to solve the problem, because the sigmoid is going to again convolute and bend on itself and going to aggravate the constipation. So a quick short video where the rectum is mobilized. So we are going in the TME plane till we reach the pelvic floor, and we have to be very careful when not to take down the lateral ligaments, both for not aggravating the constipation and also to maintain the sexual function, especially in a male patient. So this is actually the total TME plane, and you have to be very careful that you don't damage the nerves. And then you go anteriorly, because we are going to resect, so we have to totally circumferentially mobilize the rectum. So we keep a gauze around the rectum to help us have a grip on the rectum, and we are not pulling on the rectum to create any serosal tear. So here the rectum is and there we are reaching the pelvic floor. You can see the glistening structure is the pelvic floor, and then we go around anteriorly. Release all the peritoneal attachments of rectum, and then we transect the rectum just at the rectosigmoid, and then proximally we transect the at the descending colon and make sure that the descending colon comes down easily, and then we use a circular stapler to do the anastomosis, and later the rectum is pulled up and fixed to the sacral promontory using couple of non-absorbable sutures. So this actually straightens the rectum and also removes the redundant sigmoid. So these patients feel very comfortable in the post-op. One is their prolapse is gone, and also the constipation which was troubling them and which was a constant mental fixation for them gets relieved. So if in a patient you have constipation, then a resection rectopexy, if they have normal bowel habits, and then a suture rectopexy is advisable. So the major benefits being improved in quality of life in more than 80% of the patient, and most of these 80% of patients are the ones who are having constipation as one of the major complaints. The very less recurrence rate in the prolapse happening, and because we are doing it all the minimal access method, the hospitalization is short and there is less degree of analgesia requirement, and the outcomes are almost near normal with the correction of two things. One is the prolapse and the other is the constipation. And we have I'll just come back. We have one study where they have observed in 40 patients over 18 months, and they have found that the results are pretty much good when compared to only suture rectopexy. But also these patients should have biofeedback being done to them, and also a change in their diet schedule, because a lot of them may not be constipation, could have other reasons. So they should also be simultaneously corrected along with the resection rectopexy. So I would say that wherever a patient has significant constipation and the first complaint to the patient is, apart from the prolapse, is constipation, then I would prefer to do a resection rectopexy. And with improvement in our experience of doing laparoscopic colorectal procedures, our leak rate is very minimal. So we should not use leak as one reason for not doing resection rectopexy and leaving the patient to suffer from the constipation, and which in turn the constant straining would again lead to a recurrence. So back to Vandana.
Okay, thank you, Dr. Lakshmi. That was short and crisp, and the message I think you want to give is that let's customize the procedure to the complaints of the patient. Seems acceptable. Dr. Suviraj, you have a few extra minutes with you to present your arguments against. Yes.
Yes. Thank you very much. Lovely presentation, Dr. Lakshmi. We're in a debate, so let me just complete the debate function here. I really believe, and I'm sure all of you agree, that the real purpose of the debate is to bring out and highlight the individualities and the nuances and technique and approach. So let me start with where you ended. You mentioned that, for the benefit of the audience, you mentioned that your leak rate, in experienced hands like yours, is very low. But in an elderly patient who has a full thickness rectal prolapse, you do have to counsel them. So do you take the decision upon yourself to go ahead and do the procedure? Do you let them know about like a covering ileostomy? Because that becomes another procedure. How do you approach this issue of mitigating the risk of leak? I know you have the experience. How would you advise others to approach it?
See, I would if someone wants to do a resection rectopexy, then they should be sure of their coloanal procedures or their bowel anastomosis. I would not suggest that because here most of these are, like you said, are elderly patients or in beyond their middle age, who will not tolerate any complications like mainly a leak, because that is the one thing which will trouble them. But at the same time, if you have a elderly patient who has that, because constipation is one of the troublesome features of the aging. So if you have elderly patient unhappy with his bowel movements and they're constantly straining to pass stool, it is that in the post-op period they'll never be happy. So what I would suggest to anyone, that if you want to do these type of procedures, first you should improve your result rate. Because for a patient who comes with constipation, we say that I want to give you ileostomy or you leak and you will go on to a ventilator. If you say those things, the patient will never get rid of the primary problem which he has come off. So that will reduce the quality of life. So for whoever who wants to do these procedures, I would say that let us not cling on to the complication which may happen. We should try our best, even if it's 1%, that 1% should be minimized. It should not happen, that 1% should not happen. And we should take all precautions. If we are not sure, then we will tell them so many complications for that 1% which can happen. And then we give them a procedure which is not going to totally correct the complaint which they came with.
So, Dr. Siviraj, would you like to add something to that? Any counter argument to that?
Not really a counter argument, maybe a small point at the end of it. I would like to, this goes for me as well. I think I'll just maybe reverse the question to Lakshmi. What is your threshold for deciding? Because anywhere from 30 to 70% patients who come with rectal prolapse have constipation, which may be functional, which may be slow transit. How do you sort this out, especially in the day and age of specialized investigations and multidisciplinary, which I believe is the way to go forward? How do you sort that out? Where do you decide that this patient needs a resection? Where do you decide that the patient will do just well with the non-resection?
Yeah, see, because as I said, constipation is multifactorial, but where the constipation is getting aggravated by a very redundant sigmoid, then we only counsel them for a resection rectopexy. So normally, if there's a patient who says that I am taking a lot of laxatives and my bowel movements are not good, they will have a particular type of description which you understand that these patients have got a very difficult type of constipation. So, like, we have to counsel them that if we see a redundant sigmoid, we don't just tell the patient you are put for resection rectopexy right when we see them in the OPD. That's very difficult to decide. But once we go inside and there's a patient who has a very difficult constipation, you see a large redundant sigmoid, like in the video I showed you. That's why I put up that video, to see that if you have a large sigmoid just falling all over, then you proceed for a resection rectopexy. But if you have a reasonable sigmoid and the patient has constipation, then you don't go for a resection rectopexy. Then you do the other things like the fiber diet and the biofeedback and all that has to be added. So whenever a patient is with a constipation, both we have to go to open mind. We take consent for a plus minus resection rectopexy. Because to know how much of redundancy of sigmoid is there is very difficult pre-op. Even if you do a CT, maybe it will not tell you how much of redundancy is there. So always a patient with a very difficult constipation is taken with the consent of plus minus resection rectopexy to be done, and it's the on-table decision.
Okay, one question for both of you, and that is, I think Dr. Lakshmi is arguing on the basis that resection is indicated in patients who have primarily constipation as a complaint associated with the rectal prolapse. Now, what is your take on laparoscopic ventral rectopexy? I think that also has an almost equal, provides equal relief from constipation in these patients. Suppose you go in and you see a patient who doesn't have a very redundant sigmoid, then would you, counsel the patient of a possibility of either a resection or a ventral rectopexy in that case?
Yes, all patients who have constipation as a significant complaint are
Yes.
always
So,
counseled
for
for
both procedures. It can be either, depending upon that. Dr. Suviraj, would you agree with that?
Just come again, please. I missed that.
So what I was saying, we are talking basically for customizing the procedure to the complaints of the patient.
Right.
Patient of complete rectal prolapse presenting with constipation, or probably in patients who give a history of severe constipation preceding the prolapse. That means the prolapse evolved because of constipation.
Right.
In those patients, would you offer a resection straight away, or would you give them a choice that if it's the redundant sigmoid or a very large or long redundant sigmoid, the resection may be better, and if it is not so, maybe a ventral rectopexy may be the answer to their problems?
Right. Let me just tell you a few things before I come into that. Our outlook for treating rectal prolapse has taken a big shift now, especially after we started evaluating as a routine maybe over the last 5 years to a dynamic MRI. Why do I say that? Because we often recognize concomitant pelvic organ prolapse in the apical and in the anterior compartment. Secondly, we're also checking for pelvic floor distance. This is something that resection rectopexy doesn't address, I believe, adequately. So when I do anterior mesh rectopexy, I go all the way down to the perineal body, and my first stitch is often take the attenuated perineal body to bend adequately the pelvic floor. Now, why is that important? Because when you do a functional test like a dynamic MRI, you also check out pelvic floor dysfunction, which is often missed. And we surgeons often look at the rectal prolapse in a two-dimensional way, in a monocular way. But this is an anatomical problem requiring a mechanical fix. This is much more than that, and I'm sure Dr. Lakshmi also agrees. So, like you mentioned, another 30 to 70% patients who are not constipated, who have maybe a pelvic floor dysfunction, also with a mesh anterior rectopexy with counseling to the patient, that intra-op, if you find a very redundant colon or a sigmoid, we may do a resection. But again, we are happy to do a resection in a fit patient. Otherwise, in the absence of constipation being a significant problem, we offer anterior mesh rectopexy, which is a default choice. But our threshold for placing a mesh is now going up, especially with adverse reports in the West, as well as litigant activity. So a suture rectopexy along with, quick lifestyle change for smaller variants, we are taking it up first. Otherwise, it's an anterior mesh rectopexy. Now, probably going to start with more biological. But I think the complete evaluation in an MDT format, I even get sometimes a psychiatric review and even a colon transit science for people who have, I suspect a global motility disorder. So that is also there. I think the outlook of the comprehensive evaluation, your outlook will change with that. And then I think you become better at choosing which one. And as Dr. Lakshmi said, if you have the experience, in select patients, go ahead. But otherwise, I think avoid a resection rectopexy.
Okay, thank you, Dr. Suviraj. I think that was a good argument. Dr. Lakshmi, one more question for you. So far you have spoken about performing a resection rectopexy because of complaints of constipation. What about patients who present with incontinence?
Yeah, if in incontinence, you should never do a resection rectopexy. Because
so what is your take in that?
Yeah. Whenever they are incontinent, you have to find out incontinence is because of a long-standing prolapse, whether the anal sphincters have got weakened now. If then they need to retrain that after we never do a resection rectopexy for a patient who has incontinence. You should never do, because whatever leaky constipation that would be there once you straighten the rectum will actually help them with the incontinence they are having. This, along with the other physiological things like biofeedback and stimulating the anal sphincters and sphincter exercises and all, will help them. We never offer a resection rectopexy for anyone with any sort of incontinence.
Okay, there was one very interesting argument or point that Dr. Suviraj put forth, and that was regarding litigation with the use of mesh, and so their preference for a suture rectopexy. What is your take on that?
Yeah, we have abandoned using mesh for almost 15 years. We have not used the mesh in all these 15 years of our rectopexy.
So in patients where you are not doing a resection, patients of incontinence, what would you prefer to do in that case?
Suture rectopexy.
You are doing a suture rectopexy. Yeah. What about your experience with the perineal resections?
Perineal resections are only reserved for patients who are very frail and who will not be able to tolerate general anesthesia or a pneumoperitoneum. And then we do them under spinal procedures. Very frail people, there only we do a perineal resection.
Okay, so I think both the debaters seem to agree on a common point that mesh should preferably be avoided, although I think laparoscopic ventral mesh rectopexy has created a niche for itself and is doing pretty well. Yes, certainly in terms of litigation, I suppose going in for a suture rectopexy in patients who are incontinent and depending upon the anatomical anomaly associated with constipation, a resection or a suture rectopexy is what is the way forward for managing these complex problems. And apart from a rectopexy, I think a lot that is required is helping the patient manage the post-procedural problems and training them again for a normal bowel habits to avoid straining and helping in making the procedure successful. So I think with that, very difficult to decide. I think we'll agree with both of you because it all depends upon the customization. It is ultimately to customize the procedure to the patient. And for sure, one thing is for sure that a laparoscopic approach is certainly indicated in almost all patients until and unless the patient is very old, unfit for anesthesia and extremely frail. That is the only time when you can go in for a perineal. Otherwise, a laparoscopic rectopexy, whether suture or ventral or resection, both will stand the test of time and both will be applicable in different situations and different patients. I thank both the debaters for an excellent presentation. Thank you very much. And over to you, Dr. Meenakshi. I think we finished well in time, although I'm aware that we had some extra time, but I think both presenters were extremely well prepared, had timed their presentation well, and I think we've had a good discussion. So over to you, Meenakshi. Thank you very much. Thank you, Dr. Lakshmi. Thank you, Dr. Suviraj.
Thank you.
Thank you, Dr. Vandana, Dr. Lakshmi, and Dr. Suviraj. It was an excellent deliberation, and the points were well taken. There wasn't any need for more time because everything was driven home. So on that note, I would like to thank you all, and we'll move on to the plenary sessions from now on. Thank you very much.
Thank you.